I'm happy to introduce today Dr. Jennifer S. Hartman. She is a fellow of the American Academy of Optometry, fellow of the Scleral Lens Education Society, and diplomat of the American Board of Optometry. Dr. Hartman is currently an attending optometrist and associate professor, as well as the chief of the Cornea Center for Clinical Excellence at the Illinois Eye Institute, where she works with both students and residents from the Illinois College of Optometry. Dr. Hartman is one of the developers of her Insight lens design and is here today to discuss the troubleshooting scleral lens fits with the Insight Scleral.
Thank you so much for that nice introduction, Steve. I'd like to welcome you all to tonight's presentation. Here are my disclosures. So we all know that scleral lenses are gaining popularity and they are being recognized as mainstream modality to restore visual acuity and ocular surface integrity on irregular corneas. We're also using them as a valid option for vision correction for contact lens wearers, both soft contact lenses and corneal GPs. Those patients who have regular corneas and might be struggling with fluctuating vision and contact lens discomfort have been very successful with scleral lenses. There are many great scleral lens options by many manufacturers to make the fitting of these lenses more practitioner friendly. However, there is still a lot that we do not know about them, and we don't know a lot about the potential complications that may arise and the long-term outcomes of wearing scleral lenses, especially on normal corneas. What I'd like to do tonight is discuss some of these common scleral problems that we might encounter, how to troubleshoot them, along with some troubleshooting tips specific to the Insight scleral lens. Before we get into the troubleshooting aspect of tonight's presentation, I'd like to review just a little bit about the Insight scleral lens. There are so many great scleral lenses out there, so in review, what is unique about the Insight? The Insight scleral lens featuring HHM technology was developed through the collaboration of custom contact lens industry professionals and clinical practitioners. The design is a multifocal lens that maximizes both vision and comfort while maintaining a physiologically safe lens option for all corneas. The Insight scleral lens is a multifocal option for normal corneas, irregular corneas, and can also be fit for oblate corneas, for those patients who are post-surgical, those patients who have had refractive surgery, intacts, and have undergone penetrating keratoplasty. The basic fitting set has a +1 add built in, and a great feature about ordering this lens is that there is an unlimited warranty within a 90-day window, and there are no additional fees for any add-ons such as toric scleral haptics or front surface toricity. When we look at the available parameters for the Insight, as a reminder, it is available in unlimited sphere powers, still powers from -1/4 to -8. Axis is available from 0 to 180 degrees in 5-degree steps. You can order the add power up to a +3. It is a distant center. The standard diameter is a 15.2 or a 15.6, but it can be custom made up to an 18mm diameter. And the peripheral system can also be customized. The standard radius has a radius of curvature for the peripheral system of a 12.50 millimeters. And we can customize it as a flat 1, flat 2, flat 3, a steep 1, steep 2, steep 3. We can also order toric haptics when indicated. And we'll discuss this in more detail in a few minutes. Many patients have been successful with the Insight scleral lens. Clinically, we have used the lens for uncomplicated refractive errors, such as nearsighted, farsighted, astigmatic, and presbyopic patients. For patients with irregular corneas, scleral lenses are fit to increase wearing time, reduce corneal staining, and improve vision. Indications for irregular corneas include post-eye drops, keratoconus, uneven grafts, post-LASIK, and refractive surgery. Scleral lenses for damaged or diseased ocular surfaces are instrumental in reducing further damage, as they serve as a tear reservoir to allow corneal healing and improve vision. Indications for diseased ocular surfaces include keratoconjunctivitis sicca, Stevens-Johnson syndrome, graft-versus-host disease, and several others. And while many patients have been very successful with scleral lenses and the Insight scleral lens, when selecting a candidate, it's important to review patient motivation, as well as to really control patient expectations. We need to remind patients that although these lenses help improve vision, reduce corneal staining, increase wearing time. These lenses are not curative. They help mitigate symptoms, but especially in the case of ocular surface disease, patients will need to use their other therapies, as scleral lenses alone will not solve completely the problem. So when assessing what's considered an ideal scleral lens fit, we want to assess 3 key zones: the conjunctiva, the limbus, and the central cornea. When evaluating the conjunctiva, an ideal fit will land evenly on the sclera, not having any standoff or blood vessel blanching in the full circumference of the lens. It's important to not only look nasally and temporally, but also to look inferiorly and superiorly. Have the patient look down, lift up that upper lid, and make sure that we don't have any blanching or lift off under the lid. An uneven fit may require toric or quadrant-specific scleral haptics. The limbus must also be cleared. Compression at the limbus could damage the delicate stem cells. While you can use OCT analysis to help observe the clearance over the limbus, it is not necessary. You can easily observe limbal clearance with an optic section, white light, and fluorescein. And when evaluating the central cornea, ideally we should observe 150 to 250 microns of central clearance. It is easiest to observe this with an optic section and white light, and ideally we'd like to see a 1-to-1 fitting relationship between the thickness of the lens and thickness of the post-lens tear layer. So in many instances, although we'd like to see an ideal lens fitting relationship in all aspects of the lens, and as much as we educate the patient on compliance, on care, handling, in some instances we run into the problems with the scleral lens fits, whether it's because of a complex cornea or secondary to patient not following instructions. So what I'd like to do for the remainder of our time together is review the most common scleral lens problems and how to troubleshoot them to make the fitting process as successful as possible. Along the way, we will also give specific insight troubleshooting tips when indicated. So here we can see we have an ideal landing of the scleral haptic, an ideal edge. Scleral lenses should rest evenly on the bulbar conjunctiva. The haptic section of the scleral lens should rest evenly on the sclera without compressing the blood vessels or having any areas of edge lift. However, a poor fit, when we don't have ideal edge lift, can lead to redness, pain, and irritation. Lenses that are fit too tight can cause blanching and injection, and patients may complain of discomfort and reduced lens wearing time. Patients may also report on difficulty with lens removal. Here we can see blood vessel impingement and blanching, and it's really almost the whole temporal aspect of the lens. In order to troubleshoot this complication, we would flatten the peripheral curve and the scleral haptic. If you were only flatten the most peripheral curve, it can actually make the lens tighter, as it essentially can create a hinge that results in compression as the outer edge is lifted. So you would also need to flatten the scleral curve as well as the curve adjacent to it. If you notice compression, but the lens can be easily removed by the patient, it may be that the patient is applying the lens too firmly, causing the blanching. And if you only notice blanching and impingement in one quadrant or in one meridian, toric haptics will help alleviate the problem. So in this image right here, we can see conjunctival blanching and vessel impingement in just one quadrant. And this would tell us that we would require a toric scleral haptic to help flatten this area. This image right here represents a lens with moderate edge lift in the horizontal meridian. We can notice shadows under the lens edge. Patients with edge lift usually complain of lens awareness, and this would indicate that we would need to steepen the scleral haptic. If we see circumferential edge lift 360 degrees, this is usually from a result of an excessively flat fitting lens. If we see edge lift in just one quadrant, that's usually, or in two quadrants, that's usually a result of the back surface of the lens not properly aligning to the scleral shape. And this is usually found when fitting a spherical back surface on an eye with a significant amount of scleral toricity. If this is the case, and you're seeing this, patients would then benefit from a back surface toric haptics design. Once we alleviate this problem, we will notice improved alignment, patients will report improved comfort, and we will also see less reservoir debris getting underneath the lens. So for the Insight scleral lens, the standard scleral haptic has a radius of 12.50 millimeters. Ideally, we would like to see no liftoff or blood vessel impingement, and the lens should spin easily on the spin test. If we see edge lift and it's mild, 360 degrees, we would then order a scleral curve steep 1 or a 12 millimeter radius. If we see moderate liftoff, 360 degrees, then that would indicate a steep 2 scleral curve with 11.50 millimeter radius. And if we have severe liftoff, 360 degrees, that would then indicate a steep 3 scleral curve with an 11.0 millimeter radius. And then we would need to add -1/4 to the final power. Now I do want to mention that we do want to make sure that we have adequate sagittal depth, adequate tear exchange, and limbo clearance before we adjust the scleral landing. If we don't have adequate clearance over the center part of the lens, central cornea, or over the limbal area, we want to make those adjustments first before we modify the periphery. If we see vessel impingement and it's mild 360 degrees, we would order a flat 1 scleral curve, and that has a radius of a 13.0 millimeter. If we see moderate, that would indicate a flat 2 scleral curve or a 13.50 millimeter radius. And a flat 3 is for severe vessel impingement, and that would be a 14.0 millimeter radius, and we would add +1/4 to the final power. Now, as we mentioned before, most scleras have toricity, so it's unusual, unless we're doing a more smaller diameter, that we don't have to add in some toricity to the scleral haptic. So the scleral haptics can be modified as a toric 1, toric 2, or a toric 3, and you want to specify what you would like to order in the horizontal and in the vertical meridian. It's also important to allow the lenses to settle in the office for about 15 to 30 minutes before you make your final fitting assessment. And when you see these patients back on follow-up after the initial dispense, we should see them back at about 1 week, and we want to monitor any areas that we've made modifications to. Remove the lens, look for any staining. We want to make sure that those modifications that we made didn't have negative effect. So here we can perform a spin test. We want to rotate the lens with our finger. The lens should spin freely and not have any resistance. It should not catch on the conjunctiva. And if it does catch specifically in one meridian, then that again would indicate that we would need a toric haptic. When we take a look at the limbal area, the limbus must be cleared. And the reason for this is because compression at the limbus could damage the delicate stem cells. Again, we could use an OCT, but it's not necessary. The best way is to observe with optic section, white light, and fluorescein. When we're looking with an optic section, we should just be able to perceive clearance. If we don't have any clearance or we don't have any fluorescein notice, we want to make sure that we increase the clearance in that area. And why this is important is that very serious complication can rise from lens fitting is bearing at the limbus. Symptoms that patients will complain of are redness, irritation, and reduced wear time. Fitting complications that we may see from bearing at the limbus or compression at the limbus include keratitis, neovascularization, and limbal stem cell deficiency. And usually this is due from a lens with a diameter that is too small in comparison to the corneal diameter. So when we are selecting our initial base curve, our initial lens diameter, it's important that we measure the patient's corneal diameter and make proper selection based on our findings. Limbo compression can again be observed with OCT or with sodium fluorescein staining. And we can alleviate the problem of inadequate limbo clearance by increasing the overall diameter, increasing the optic zone width of the peripheral curve. These will allow increased vault or landing over the limbal area. So just taking a look specifically with the Insight lens, an ideal fit is going to reveal a 1 to 1/4 relationship between the thickness of the lens and the thickness of the post lens tear layer. The standard Limbal Curve of the Insight lens is a 10.25 millimeter radius. If we don't see any fluorescein at all, we need to steepen that Limbal Curve by 0.1 millimeters, and that's going to equal about 100 microns. And by changing this, this is not going to have any effect on the base curve or on power. If we have excess fluorescein at the limbus, we will decrease the Limbal Curve by 0.05 millimeters or 50 microns. So a couple of examples here. Here we can see an image that has appropriate clearance, just perceptible sodium fluorescein. And again, we want to make sure that we allow these to settle in office for a good 15 to 30 minutes. Here we can appreciate excessive limbal clearance. So we need to reduce the limbal curve. We want to decrease the sagittal depth over the limbal area by 100 microns, 0.1 millimeters. And here we have inadequate clearance. We worry about compression over time. So we need to increase the depth by 50 microns or 0.05 millimeters. So this image represents an ideal central vault. We have that 1-to-1 relationship between the thickness of the lens and the thickness of the post-lens tear layer. Remember that the goal of the scleral lens is to completely vault the corneal surface, including the limbal area. And sometimes, especially with advanced keratoconic patients, we might see signs of bearing. So to help increase that central vault, that sagittal depth, steepening the base curve will increase the sagittal depth, or increasing the overall diameter will increase the sagittal depth. So for the Insight scleral lens, the diagnostic lenses have a center thickness of about 0.25 millimeters. So ideally, the thickness of the post lens tear layer, we'd like about 150 to 250 microns of clearance. Those patients who have more irregular corneas or ocular surface disease, we err on the side of 200 to 250 microns. Those patients with more normal corneas, we would err on the side of more 150 to 200 microns. Lenses are going to settle anywhere from 50 to 150 microns on the eye, depending on the softness of the conjunctiva. If we see excess vault, we flatten the base curve by 0.1 millimeters until we achieve the desired clearance. 0.1 millimeters equals 100 microns. And for every 0.1 millimeter base curve change, we're going to add either plus or minus 1/2 to 3/4 to the final power, depending on whether we flatten the base curve or steepen the base curve. If we have inadequate vault, we're going to steepen the base curve by 0.1 millimeters until we have the desired clearance. Now, sometimes with excess vault, we might notice a large bubble. The one thing that we need to make sure is that this is not due to an insertion bubble. So if you do see a very large bubble upon insertion, especially over the pupil, I would remove the lens, use a more viscous solution to fill the bowl of the lens, reapply, and make your assessment there first before modifying any changes to the base curve. Most of the time when you see that large bubble, it's going to be due to insertion error. So as a reminder, to select your initial base curve for the Insight, you want to take a look at whether or not the patient has a normal cornea or diseased surface versus corneal ectasia as post-surgery. For those patients with standard corneas or diseased surfaces, if they have corneal cylinder less than 2.5 diopters, you're going to select your base curve 0.4 millimeters steeper than flat K. If they have corneal cylinder greater than 2.5 diopters, you're going to select your base curve 0.3 millimeters steeper than steep K. And for patients with corneal ectasia or who are post-surgical, regardless of what amount corneal cylinder they have, you're going to select your base curve 0.3 millimeters steeper than steep K. And if K readings are unattainable, whether that's due to poor tear layer or corneal scarring, if the patient has a more regular cornea, you're going to select a base curve of 7.2 as a starting point. And if they have more irregular cornea, select your base curve of 6.8 to 7.0 as a starting point. You could also use corneal profile and select your lens base from there. So here's an example of excessive central vault. So concerns here, if we allow this to continue, could be hypoxia. We might see signs of corneal neovascularization, Patients may have a hard time removing the lens. They would have reduced wear time, redness, and they may also complain of reduced vision to tear reservoir debris that collects between the lens and the cornea. So due to this excessive central vault, we can see the thickness of the lens and then the thickness of the post-lens tear layer. This is showing about a 1 to 4 or 5 fitting relationship. So we would need to decrease the sagittal depth by about 300 microns. So we'd flatten the base curve by 0.3 millimeters and add plus to our final power. When we take a look at this image, we can see that we might have appropriate clearance superiorly, but as we move centrally and inferiorly, we have inadequate central vault. It's touching the lens's bearing on the cornea. So here we would need to increase the sagittal depth by about 200 microns. So we would steepen the base curve by 0.2 millimeters and then add 1.5 diopters of minus to the final power. We also notice that the lens is sitting slightly inferior. And occasionally, the mass of a scleral lens can result in inferior decentration. Usually this is not a significant problem, but this may contribute to corneal bearing. To help alleviate decentration issues, you can decrease the overall diameter or add on toric haptics to help improve the centration of the lens. Make sure to have the patient remove their lenses and stain their eye at follow-ups. We don't want to see any staining. If we see staining, then that would tell us that we need to make some modification, whether we see staining on the central cornea, at the limbus, or at the conjunctiva. Again, lenses settle anywhere from 50 to 150 microns. So really it's important for these lenses to settle in office doing your initial fit, and then it's important for these patients to come in for their follow-up with the lenses on their eyes for at least 2 hours minimum. Another area of concern that we might see are areas of mid-peripheral bearing on the cornea, as this can contribute to epithelial changes and decrease wearing time secondary to discomfort. This often occurs when a prolate scleral lens design is used to fit an oblate cornea following refractive surgery or a penetrating keratoplasty. So in this top image here, we can see this patient has had a penetrating keratoplasty and was fit with a prolate lens. So just looking centrally here, we might have appropriate tear exchange 200 microns. But we see areas of mid-peripheral bearing, which is not appropriate. And then as we get closer to the graft-host junction, we worry about compression. By changing this patient to an oblate design, not only do we have less bearing in that area, this also increases and improves the overall sagittal clearance. Switching to a reverse geometry or an oblate shape will improve the lens ability to vault over that mid-peripheral cornea and keep the overall cornea much healthier. And again, this is a patient with refractive surgery. We can see that mid-peripheral bearing as the mid-periphery is steeper, so this patient would do much better by having an oblate shape, steepening that limbo curve, and you can request an oblate shape lens with the Insight scleral lens as well. Some patients have significant penguiculas or pterygium that can significantly alter the scleral shape. They may have redness, irritation, they may not be able to wear their lenses as long. So if we have patients who have significant penguiculas or pterygiums, we may need to go to a smaller overall diameter, or for some patients who have really large penguiculas, we may need to notch the area by about 1 to 2 millimeters. If you're having difficulties with any of these patients and the troubleshooting can become quite complex, I would encourage you to take photos of what you're seeing and send them to the lab, as the consultation can be quite helpful in helping you decide what parameter you need to change. A common, or maybe a not so common, problem that we might see is conjunctival prolapse. And conjunctival prolapse is entrapment of the conjunctiva that drapes over the cornea near the limbal region under the scleral lens. It usually occurs in the inferior quadrant in patients who have conjunctival chalasis and also in elderly patients. So if we do notice this, things to look for are, is the lens too large for the patient? Is the diameter too large and do we need to go smaller? Is the scleral lens decentering? Is the lens fit with excessive clearance over the limbus? And do the patients have conjunctival tissue that is sitting below or lower than the cornea? Usually this condition is benign, but we really don't understand and know the long-term outcomes. So we really try to alleviate this as much as possible as the conjunctiva is draped over the stem cells for several hours. So what are things we can do to help prevent or alleviate prolapse? We want to limit clearance over the limbus by modifying the peripheral curve. We want to select a smaller overall diameter. We can review application techniques with the patient to make sure that they are not applying the lens with too much pressure, as this can also induce prolapse. And again, we can reduce limbo clearance by decreasing the sagittal depth over that limbo curve. So we just went over some common fitting complications. Now what I'd like to do is go over some patient complaints that we might encounter. One common complaint that we might encounter is complaint of pain or discomfort or lens awareness. And the majority of the time, lens awareness and discomfort is caused by lens to lid interaction, mostly when the lenses are fit too flat on the conjunctival tissue. If we see edge lift, this will cause lens awareness and discomfort. To help us to determine whether or not it's the lens edge contributing to discomfort, you can pull the lids away from the edge, and if the patient notices that their symptoms improve, then we know that it is in fact the edge contributing to their symptoms. If the patient reports that they feel the lens or they're aware of the lens under the top lid, this usually indicates that the periphery is too tight, so we would need to flatten the scleral curve. If they are more aware of the lens at the bottom of their lid, this indicates that the peripheral curve is too flat, so we would need to then steepen that curve. Other reasons for patients complaining of discomfort or irritation or lens awareness could be because of solution sensitivity. They may be using the wrong solution to clean their lenses with or to fill their lenses with prior to insertion. They could be not rinsing the cleaner off completely, or they might have a bubble trapped underneath the lens. If bubbles are trapped under the lens, the patient will report burning and discomfort, and this is usually secondary to tear stagnation. Usually revisiting handling with the patient will take care of this issue. And some patients, especially when they're first learning how to apply and remove lenses, will need a more viscous solution to fill the bowl of their lens. If there's corneal touch or corneal bearing, a patient may complain of discomfort. Upon removal, they may induce a corneal abrasion. So in those instances, we would need to steepen the central vault, steepen the sagittal depth. If patients report that overall they're aware of the lens and they notice it upon blinking, it could be due to a poor surface. So it may be we need to treat their ocular surface disease more aggressively. We may need to treat the surface of the lens. And it could also be due to Tightline Syndrome. If patients complain that the discomfort of their lenses occurs after about 4 to 5 hours of wear, and they say that, initially when they put the lenses on, everything feels fine. The first hour or two, everything feels fine. But after 4 to 5 hours, they're noticing discomfort. This is what's called Tightline Syndrome. The lens is becoming too steep. It's starting to seal off the ocular surface. So to improve this, we would reduce the overall lens vault and flatten the peripheral curve. And if after we've done that, the patient's still getting a Tightline Syndrome, we can reduce the overall diameter of the lens. So this is a patient who is using multi-purpose solution instead of a preservative-free solution to fill the bowl of the lens prior to insertion. And here we can see diffuse corneal staining all across the surface. Solution toxicity will often reveal diffuse corneal staining, and patients will complain of burning, redness, and tearing. So if we see this, we really want to review, make sure that the patients are using the proper solutions to not only clean their lenses, but to fill their lenses with. And a lot of times it's just spending time with them, making sure that you review the history. Sometimes they'll say, well, I can use this solution to clean my lenses. I'll just top off and fill the bowl of my lenses with this to save some money. But some patients are extremely sensitive, especially those with ocular surface disease. So this patient right here is a patient who had Tightline Syndrome, and this is because the vault was a little bit excessive. Even though we see that the diameter looks appropriate, the vault was not, extremely excessive, but we did see that it was more around the 300 to 350 microns, assuming that this patient would settle more over time, but did not. To help alleviate the situation, we would reduce the overall vault, reduce that base curve, and then flatten the scleral haptic. After we had done those, if this was a larger lens and those two modifications did not alleviate the situation, then we would go ahead and reduce the overall diameter. So another common complaint that patients may present with is blurred vision. And blurred vision could be due to bubbles, surface debris, lens reservoir debris, and it also could be, do we have the incorrect prescription? So bubbles are usually due to mishandling during insertion. If we see a large central bubble, we want to remove the lens, ensure that the lens is filled completely to the brim, almost so that it's overflowing. Make sure that the patient's face is parallel to the floor. Use a more viscous solution. Have them use a suction cup. And then after we've assured that the patient is doing everything properly and we're still getting bubbles, then we may need to decrease the vault, as it could indicate that we have too steep of a base curve. If we see peripheral bubbles, that could indicate that there is too high of edge lift. So small air bubbles can form under the surface of the lens during eye blinks if there's significant edge lift. And then those small bubbles can form a much larger bubble under the lens, contributing to reduced vision. To help solve that problem, we steepen the haptics or order toric haptics. Here we can see moderate edge lift, and as the patient blinks, we have small air bubbles are starting to form under the surface of the lens. If we were to leave this alone, the small bubbles could then form a much larger bubble under the lens, and patients would complain of lens awareness on the inferior lid, and we would then order this lens with a toric haptic, steep 1 or steep 2 in the vertical meridian, and standard in the horizontal. What we want to make sure to do is spend the appropriate time with the patient reviewing handling techniques. Make sure that the patient is using the proper application tools, whether that's a DMV, a 2 or 3 finger tripod method. There are dental bands available, and also make sure that they are familiar and comfortable with lens removal. There are great INR videos available. But really, patients should not be leaving the office until they are completely comfortable with application removal, as well as they fully understand what solutions to store, rinse, clean their lenses with, and what solutions to fill the bowl of their lenses with prior to insertion. There are many conditions that may cause poor anterior surface wettability, and surface noun wetting may also cause blurry vision. Conditions that may contribute to poor surface wettability include patients with severe dry eye. We see this in conditions such as graft versus host disease, Stevens-Johnson syndrome, meibomian gland dysfunction, blepharitis, and rosacea. To help manage this, we want to control patient expectations. We know that with scleral lenses, we use a higher decay material, and these materials tend to be more hydrophobic, and so these may not be great for patients who tend to have heavy deposits. Aggressive treatment of the ocular surface disease is imperative. Patients who tend to have heavy fogging throughout the day, it may be also due to the type of makeup that they're using, the type of soap that they're using. Are they using oil-based lotions? So we want to review all the different things that they're using throughout the day. It's important to educate patients to apply makeup after scleral lens application. Patients who still have problems with non-wetting, they may need to use more frequent rewetting drops, preservative-free. The windshield wiper technique with using a sterile cotton tip applicator may help remove deposits. Using the squeegee technique with a suction cup is also beneficial. Some patients may need to remove, clean, and reapply their lenses throughout the day. Some individuals may also need to use stronger cleaners, and others benefit from surface treatments. So a HydroPeg may be used for any patient. It is a surface coating that helps minimize deposits. There are no contraindications, and patients who tend to benefit the most from these are those who experience discomfort and dryness with lens wear, patients who have heavy deposits, and those scleral lens wearers who experience fogging throughout the day also do very well having their lenses treated with HydroPeg. Now, for patients who have their lenses treated with HydroPeg, it is important that they avoid tap water with their lenses and avoid abrasive or alcohol-based solutions. Hydrogen peroxide and approved multi-purpose solutions should be used. HydroPeg may last permanently, but it is variable depending on the patient's condition. We see a shorter duration of effectiveness for those patients who tend to have heavy deposits or patients with more severe leg ophthalmos. And for patients where lenses have been treated with HydroPeg, we need to educate them that the lenses may be more slippery, so the handling, inserting, and removing adjustment period for those patients may be a little bit different than those who do not have HydroPeg on their lenses. So another reason why patients may have blurred vision may be due to tear reservoir debris. Patients with tear reservoir debris will complain of midday fogging. There are a couple of theories as to why this occurs. Patients who have more debris tend to have higher lipid concentrations on the ocular surface. If a patient has a poor peripheral landing of their scleral lens, this will allow for uptake of debris from the tear film into the reservoir. If the wrong solutions are being used to fill the scleral lens prior to application, this can contribute to debris under the lens. If there's excessive scleral lens vault, we want to minimize vault by decreasing the overall sagittal depth and decreasing the overall diameter. Some patients, if their scleral lens is rubbing on the bulbar conjunctiva, that can also generate debris. So the first thing that we would do is adjust the fit. We want to eliminate any signs of touch and minimize vault and excess edge lift. If the patient is using the wrong solution, we will try filling the bowl with a few drops of preservative-free artificial tears. Also, we want to rinse the lens with preservative-free saline, storing in preserved solution prior to lens application. And we can also recommend what's called a morning eye dunk prior to lens application or midday side rinse with preservative-free saline. Another option would be to order the scleral haptics as a toric haptic, as this will lower the mechanical stress on the conjunctiva. And here we can see here that we have some debris between the lens and the cornea. In this patient, we have much more excessive debris. And in this patient right here, this is going to contribute to reduced vision. The other thing that we need to check for is if a patient complains of blurs is to make sure that we have the correct prescription. In order to do this, it's as simple as performing an over-ret or over-case. Take a look at the pupil size, make sure that we have the correct add power. Most of the time the lens does not flex, but we do want to make sure that we do not have lens flexure. And then if we do need to, we can order front surface toricity, surface treat, and then we also have the KW stabilization feature on the Insight scleral lens to also help with that front surface toricity. So KW stabilization is an HHM technology unique to the scleral, the Insight scleral. It helps stabilize the scleral lens on the eye, especially for front surface astigmatic compensation. The lens is adjusted in particular regions and it allows for reduced thickness. It can be used on presbyopic compensation as it adds magnification, especially in add powers at +1.5 and greater. The KW stabilization also adds a high definition feature for distance compensation of astigmatism by reducing aberrations on eye, and this can be extremely important in helping with vision, especially as for those irregular corneas who have higher order aberrations, such as coma trefoil. So when we're determining our lens power, it's important to perform a sphericil over-refraction. If a patient does need an add, we want to specify the add and pupil size for each eye. And then again, make sure that we're using the correct profile for the cornea. If a patient needs an oblate profile, especially for those post-surgical cases, let's order as an oblate profile so that the patient gets the best vision potential. The power for adds for the insight is produced mathematically by curve differential optics, another HHM technology. So the add power is not at the center of the lens, but it begins at the margin of the central distance zone and increases in power similar to a progressive. So the add you can get all the way up to a +3, and you can get this for any cornea. But it's really important that you specify what add that you need. Make sure that you do it for each eye. So we reviewed fitting problems, patient complaints, and we're going to finish with some ocular problems that we might see. So corneal edema, a lot of these ocular problems that we might see, especially corneal edema and bulbar redness, they're not extremely common, but if we do see these we want to address and treat aggressively. Scleral lens wear may induce corneal edema if we have lenses that are fit with excess vault and we let the patient stay with these lenses. So lenses fit with more than about 200, 250, or 300 microns of clearance and who are wearing very thick lenses, what happens is we get a hypoxic stress on the cornea. We might see neovascularization and infiltrates. So this patient down here, this patient came to us wearing this lens to be refit. And you can see this patient's wearing a very tight fitting lens. So the lens had excess vault, but we're getting some compression as well, but we have some neovascularization down here. So we're getting signs of hypoxia. So this lens definitely needs to be refit. Corneal bogging is not necessarily a complication, but it is something that we might see upon removal of the scleral lens. And when we look at the corneal surface, the surface looks what's called waterlogged and irregular. And the thought is that this is resultant from contact between the epithelium and a sodium chloride inhalation solution that does not contain electrolytes. Patients who have this are normally asymptomatic, and this is a relatively benign condition, and usually switching solutions to fill the lenses with and making sure that we have appropriate vault over the central cornea will solve the problem of corneal bogging. We don't want to see any signs of ocular surface staining. If we see central corneal staining, it could be due to a solution toxicity or not enough central vault. So we want to make sure the patient's using correct solution and then increase the vault as indicated. Limbo corneal staining could be, again, due to solution toxicity or not enough limbal clearance. And conjunctival staining is usually due to too steep of a scleral haptic. So number one, if we see staining, we want to make sure the patient is using the proper solution. And then we would want to make sure that the lens is fitting the proper way. If a patient uses the solutions, again, that contain preservatives, it's going to create a toxic or hypersensitive reaction. Make sure that the patient isn't using multi-purpose solutions to fill the bowl. Toxic reactions are going to be noticed usually immediately, whereas hypersensitivity reactions are going to be delayed. And bulbar redness that we might see could be due to a variety of problems, and it may be due to infection, mechanical trauma, irritation, blood vessel compression, or inflammation. And thankfully, very few cases have been reported of infection or microbial keratitis reported to or related to scleral lens wear. And patients who have severe systemic disease or who are severely immunosuppressed are going to be more susceptible to these complications. And for those patients who do have significant systemic disease or who are immunosuppressed, who have severe ocular surface disease, we do want to watch those patients and follow them more closely. Patients who have mechanical trauma or blood vessel compression, we're going to see impingement when the spherical lenses are used on toric surfaces. So by using toric haptics will allow for increased comfort, wearing time, and decreased redness. And for patients who have chronic inflammation, especially with ocular surface disease, we might see cellular debris becoming trapped under the lens, which will then initiate the inflammatory reaction. So making sure that the surface disease is treated aggressively and then maintaining the appropriate amount of sagittal depth under the lens will help with those issues. So here's a review of some of the common problems that we discussed and that you might run into, but hopefully some of the troubleshooting tips that we discussed will help you along in the process. In summary, just a few things that I'd like to highlight. Scleral lenses are becoming more and more popular, and they are very instrumental in helping many patients, but proper candidate selection is extremely important. Some patients, based on their lack of motivation or their systemic health, their inability to return to follow-up are not good scleral lens candidates, and that's okay. Having that conversation with them up front about what's to be expected of them needs to be had, and then based on that conversation, you can make the decision together as to whether or not to proceed. It's extremely important to allow the lenses to settle on the eye for 15 to 30 minutes in office before making your final fit and vision assessment. This is going to save a lot of time and reorders. We want to control patient expectations, especially for those more irregular corneas and for those ocular surface disease patients. Scleral lenses are going to help mitigate their symptoms, but they're not going to be curative. It's imperative to spend time with patients to ensure that they properly know how to handle lenses and start remove them, as well as know the proper solutions to fill the lenses with and to clean the lenses with. When seeing these patients back for follow-up, they should have their lenses on their eyes for several hours so you can really appreciate how they've settled. We want to see them back within a week for the first follow-up. Some patients with systemic disease and ocular surface disease are going to be monitored more often. And some problems we're not going to be able to resolve 100%, but our goal is to minimize them as much as possible. We have some great resources available, so we should utilize them. If you're having difficulty, take photos, send them to the lab, speak with consultation, as they can be extremely helpful. So I hope that you found tonight's discussion helpful. I hope that you can take some of these troubleshooting tips back with you as you see these patients. Again, you're not going to see a lot of these, but if you spend the appropriate time at the initial fitting and spend time looking for these problems at follow-up, I think that you will be successful in fitting in the long run. Again, thank you for your attention. I hope that you all have a great rest of your evening. If you have any questions about tonight's discussion or about any of the Insight fitting features, you can feel free to email us at any of the email addresses listed here.
Well, thank you, Dr. Harthen. I do have a couple of questions real quickly before we wrap things up here. Do you mind?
Not at all.
Okay. Got one question here. It says, when you examine a cornea in conjunctiva post lens removal, what are you looking for? Specifically, if lens was perhaps too tight.
So if the lens was too tight upon lens removal, I would look to see if there's any corneal staining at the limbal area, if there's any staining on the conjunctiva. The other thing that I would look for upon lens removal is I'd look to see if there's a compression ring of the lens upon removal, or see if there's a ring of redness from where the lens was resting. Okay.
And then one other thing, whenever you're fitting these scleral lenses, what is your recommended follow-up schedule to help avoid any potential problems?
So when we see these patients back for follow-up, part of it's going to depend on the condition in which we're fitting them for and how severe their condition is. But for initial dispense, we're going to see them back for their first follow-up after a week, and then usually in a couple weeks following that, then anywhere from 1 to 3 months, and then every 3 to 4 months. Again, those patients who have severe systemic disease or ocular surface disease, we're going to watch those a little bit closer. But for sure, that first week after dispense, and then again about a month, and then 3 months.
Okay. And then one final question, do you find that prescribing with these lenses, are you using toric haptics more often than not?
I would say yes. Maybe initially, several years ago, we weren't, but part of that was maybe we didn't fully understand the toricity of the sclera, but now that we have more resources available and we're understanding the shape and how the lenses perform on the eye, definitely ordering more lenses with toric haptics. This helps alleviate a lot of the problems as far as the fitting complications that we see and patient complaints.
Thank you to Dr. Harthen for your wonderful information today. If you have any more questions about the contact lenses and our policies, please give us a call at 800-223-1858, or you can email us at metro-optics.com. And thank you very much for taking the time to visit with us today. And I hope you found this useful. Thank you again, Dr. Harthen. Hope everybody has a good evening.